Honorable ladies and gentlemen, colleagues and friends, thanks for the invitation. I don't know how many of you are aware that 3.8 million patients have been treated in the NHS presented with an acute or chronic wound in the years 2017 and 2018, and that's according to the guest report. And there's no better word to define patient, from the Latin patire, to endure and suffer, to describe the conditions of people that are living with a chronic wound. Interestingly, up to 13% of all these wounds are lower limb leg ulcerations with an arterial component. And more worryingly, an additional 10% of those have never had the underlying etiology being diagnosed properly. In reality, in real-world practice, 1/3 of lower limb ulceration, they are secondary to peripheral arterial disease, PAD. And the PAD affects 1 in 6 people age 60 in the UK. And although the early stages of PAD may be presenting with symptoms of inconvenience like intermittent claudication, pain on exertion, the truth is that the natural history of PAD is one of subtle and progressive and disabling nature. The end stage of peripheral arterial disease is characterized by the presence of unbearable ischemic rest pain, leg ulcerations, and we address to that scenario as a critical limb ischemia or chronic limb-threatening ischemia. To suggest that most of these conditions, they may quickly progress to life-threatening sepsis, limb loss, and death. CLI, critical limb ischemia, when left untreated, leads to death and limb loss. At 1 year, 55% of CLI patients, when not treated properly, they will be either dead or living without a limb. And in terms of epidemiology, in a constituency of approximately 65,000 people, every other day, one person will present with a critical limb ischemia or a diabetic-foot infection. And that means that in a large vascular center, like Guy's and St. Thomas's, where I have the honor to lead the lower limb services, that we are a hub for a network, the Southeast Network, with a catchment area of approximately 3.5 million people. Every day we are committed to assess and treat 4 CLI patients and up to 20 diabetic foot infection. And this is a global pandemic. Before COVID, approximately 28,000 revascularization surgery, bypass or endovascular treatment, angioplasty and stenting, were performed as a limb salvage last resort. And despite that, up to 6,000 people experience a major lower limb amputation for unsalvageable limb condition. And the situation has not improved in the wake of post-COVID. My team at St. Thomas's has published a prospective outcome analysis showing that patients with CLI, critical limb ischemia, who underwent surgery during COVID, 1 year later, they are still experiencing worse clinical outcome with a poorer amputation-free survival and freedom from major adverse limb events. The good news is that the evolving technologies in the diagnosis, in the treatment, either by bypass surgery or cutting-edge endovascular treatment, together with the implementation of evidence-based best medical therapy, new technology in wound care strategies, they do offer opportunities to improve the care and to address the unmet needs of this vulnerable population. But although there are centers of excellence, and you have heard before Imperial, St. Thomas's, and other centers across the country, the reality is that there are huge discrepancies in the delivery of care. In 2018, the GIRFT, Getting It Right First Time, which is an NHS England initiative together with the Royal Colleges and the medical associations, has highlighted that there is a huge discrepancy in the provision of vascular surgery across the country, and that has a huge implication in the overall final clinical outcome. And the year later, in 2019, the Vascular Society of Great Britain and Ireland has published a quality improvement framework and has established the new guidelines recommending that all patients with critical limb ischemia should be treated within 2 weeks from the initial GP referral, or within only 5 days if they happen to be admitted in hospital. And this is a huge task for the whole NHS system. Just to give you an idea, according to the National Vascular Registry, between April and December last year, only 51% of the vascular intervention met the target. And in high volume centers, the target was as low as 20 to 30%. So with these thoughts in mind, I want to share with you what I think they are the 5 major challenges that we need to face and win together. 1, to implement and to improve a multidisciplinary approach to the lower limb condition, to have a joint effort between vascular diabetes specialists, nurses, both the tissue viability specialists and community nurses, podiatry, GP services, together to offer a timely services. At St. Thomas's, we have implemented what we call the EVC, the Emergency Vascular Clinic, that even during COVID, we're able to offer 5 days a week, one-step clinic, nurse and consultant-led to deal with lower limb condition. Number 2, time is tissue, as we say. Time is the essence, and the clock starts at the time of diagnosis. So the time starts in the community. We need to close the gap between the primary and tertiary care. We need to reduce the RTT, the time from referral to actual treatment. Again, that's by necessity means that we need to bring the expertise back to the community. Number 3, we need to rethink the model of centralization of the vascular services, the model of hub and spoke. That does not really meet the need for lower limb condition. You as an MP, you need to think in your community, where is the nearest vascular center? Are you aware how long does a patient presenting with a gas gangrene in the foot, how long does it take to be referred or transferred from their local hospital to St. Thomas's? It may take 5-10 days, and by that time, the gangrene has reached above the ankle and the limb is unsalvageable. So we need to rethink the centralization system. Number 3, we need to support the charitable sector. And the leg club model is probably the epitome of how a good work can be done within the community, listening to the patients and to the experts. And finally, reaching for the vulnerable. We need to include the population that has often been excluded. People living with a wound in the lower limbs, having a mental condition, living rough on the street, being homeless, or being burdened by a chronic addiction. Those are the people that are not on our statistics, that are not included in our outcome studies. And I would like to terminate this by mentioning the amazing work of Jamel Gertie, which is a tissue viability nurse consultant and lecturer at King's, and a trustee of the Ellie Lindsay Foundation, that single-handed before and after COVID has run nurse-led clinic for homeless in Camden and across Kent. Those are the examples that we need to look for, and we need to expand in the country. Thank you.